Thank you very much. It has really been a pleasure to be here. I've been treated incredibly kindly and have eaten very well and, and have not quite learned how to say Louisville, but I'm working on it. Anyway, it has been just a delight, and I am pleased to be here. I have a little bit of the imposter syndrome going for me, I think, because it's rather odd to be sort of a student and a speaker within 2 days, you know. So hoping I can pull this off together with you all here. Since we are a small group, and now you have just heard about me, I was wondering if we could take just a minute so I could just find out who you are. If this were a larger group, maybe we could forego that. But just to know who I'm talking with, it'll help me maybe say or not say something or other. So if you guys are open to that, I'd be grateful just for a minute. We can start over here. Some of you I've met, but I assume you guys all know each other, yeah? Okay, well then that's good. So we can do that too.
I am Ron Oliver. I serve as the Associate Vice President for Pastoral Care for North Healthcare.
Terrific.
I'm Paul Simmons.
I'm Trudy. I'm Andrea Sinclair. I'm also a student enrolled in the Bioethics Master's program.
Tony Martin at the Department of Medicine.
Ruth Simons, and I'm a hospice physician. I'm the director of pelvic care service at Jewish Hospital.
I'm Ken Holsapper, usually chairman of family medicine, and now we work in geriatrics.
I'm Billy Andrews, and I'm former chairman and chairman emeritus of pediatrics at the University of Louisville, and for 8 years was a visiting fellow in medical history, ethics, and humanities at Oxford University.
Wow.
Well, I wasn't.
I'm Melissa Bishmigelski. I'm the assistant director at Kornhauser Health Sciences Library, and I'm the social and behavioral educational IRB.
I'm Stephen Hansen. I'm a philosopher who works in medical ethics.
And he's on the IRB too.
And I'm on the IRB too.
Indeed he is.
And I've already said my hellos, so you want to.
Terrific. Well, thanks. That helps me know who I'm speaking at, and hopefully it'll help me think about a thing or two to say or not to say here. All right, so I was kind of tongue-in-cheek here, all in the family, clinical ethics and the family physician. I'm a family doctor. That's what I am, that's what I do. And so my hope here is, and primarily I'm a clinician and a residency educator. I have dabbled in ethics stuff for, gosh, off and on, I guess, since I was a medical student, which was a long time ago now. But I am primarily a clinician and a residency teacher. And so my comments really come from that perspective, all right? You know, I'm learning. I'm a student again. So, you know, I'm learning stuff that some of which I thought I knew a little, some of which I didn't know at all. And so I just ask you to keep that in mind because you're getting a family doc's perspective. Sometimes when I talk to residents about how to get a consult, for example, on one of our patients, you know, what I'll say is, you know, if you don't want the cardiac catheterization, don't call the cardiologist. Because we all tend to do what we do, right? And we see life from our perspective. To some extent, everybody's an existentialist, right? I mean, everybody sees life from where they are. And, you know, that's as it should be. The trick is to try to see things from another perspective. And to the degree I really try to do that, I think it makes me better. But at the end of the day, I am a family doc. And so I'm not going to apologize for that. But that's what you're going to get out of this, hopefully. Right. So some objectives, just for the sake of stating them clearly. We're going to talk about 4 general goals of medicine. Hopefully, you'll be able to discuss differences between the traditional biomedical model and the biopsychosocial model of care. Hopefully that will be obvious. We'll talk about some core philosophical principles and attributes of family medicine. We're going to talk about 6 components of the patient-centered clinical method. And then, after kind of doing all of that family practice-y stuff, we're going to talk about how this background in family medicine will influence a family physician's approach to clinical ethics cases. And in fact, we have a case. So we're going to do that first. And that'll take a minute because it is, and hopefully it'll be obvious as we go through, but this is long, and it's long on purpose. And we'll come back to that. Okay, so I'm just going to read this out loud with you all. And I may refer to it a little bit during the presentation. Clearly, we're going to have lots of time at the end. That's my plan anyway. And then hopefully it'll help tie some of these themes together for us. Okay? So, Gabriela Rivera, and let me say, because this morning I was politely admonished for not specifically saying this is a pseudonym, this is a composite case. So it is. In fact, hi, welcome. And let me also say, and I didn't say it this morning, that these cases have been adapted and reprinted with permission from my friends from Santa Clara University. They have an ethics center there, a broad ethics center. They don't just do healthcare stuff. And somehow or other they tracked me down last year sometime and said they were wanting to work on some cross-cultural medicine cases, and would I help them develop cases and write a bit of a commentary. So I said, sure. So then I said, well, can I borrow them back? Because having helped develop them, I'd sure like to use them in some other venues. And they said, fine. So that's the disclaimer, and I told them I'd give them some credit. All right, so Gabriela Rivera, not her real name, is an 80-year-old Latina immigrant who lives alone in a small house in Salinas. Salinas, for those of you that don't know, Salinas is in central California, about 100 miles south from San Francisco, 15 miles inland from Monterey and the Monterey Bay. Plug for vacation, if you're ever interested in coming to our area, you can go to the Steinbeck Center in the morning, which is the best museum I've seen dedicated to an author. Not that I've gone to that many, but and go to the Monterey Aquarium in the afternoon and eat on Pebble Beach that night. And I'm not a golfer, but if you're a golfer, you can probably squeeze that in there somewhere too. At any rate, so Salinas is in Central California. It's in Monterey County. I work for Natividad Medical Center, which is the county hospital for Monterey County. Most of my patients are Latino. Nearly all of them are public sector kinds of patients. Okay. So Gabriela has lived in the U.S. for 40 years and speaks some English, although a little hesitantly. Her primary language is Spanish. Though she's now retired, she used to work in the fields where she was exposed to a variety of agricultural chemicals, some of which are now considered toxic. Her husband died 4 years ago of a massive heart attack. She has 6 adult children, 3 of whom live out of the area. Gabriela is a devoted mother, calling her children as often as she can afford and even sending them homemade sweets. She raised her children through their teenage years in the same little house in which she lives today in East Salinas. And she is loath to leave it, although she now pays the rent only with difficulty, especially this year, and with financial help from her children. She has long suffered from high blood pressure, which she controls with medication. She also has type 2 diabetes. When she was originally diagnosed with diabetes, she met once with a nurse who advised her on diet, exercise, and weight control, but Gabriela has found it difficult to adapt her traditional tastes in food and lifestyle to the recommendation that the nurse offered. Subsequently, Gabriela's doctor prescribed medication to help keep her diabetes under control. She tries to take her medication whenever she can remember and when she can afford it. Recently, tests have revealed that her kidney function has been declining. Her youngest son, Marcos, lives near her. He speaks fluent Spanish and good, though very accented, English. He checks on his mother as often as he can. He's an agricultural field foreman, which is a pretty good job. Married with 3 teenage children. Daughter Cecilia spends a great deal of time in her grandmother's house doing homework, helping out with chores, checking in, getting loved, all that stuff that grandmothers and grandchildren do. Marcos was also recently diagnosed with diabetes. No great surprise. He learned of his disease at a community clinic from a doctor who advised him to make major lifestyle changes in order to prevent worsening of the disease. He's a moderate to heavy drinker, but refuses to cut back on drinking since he can handle it. And it is an important part of his social life. He also has a great fear of needles and recoils at the idea of having regular blood tests. He reasons that he will just learn to live with his symptoms, which at this point are still pretty mild. He's only 49. Lately, Gabriela has had an increasingly persistent cough, and she suffers from headaches, shortness of breath, and just generally not feeling so good. She's been ignoring these symptoms, however, and writing them off to her insomnia. Right. Stoic, older, Santa. I call the older Latina women las mujeres santas. They're the saintly women because their job is really to take care of their families and not so much to worry about themselves. One afternoon on her way home from work, Marcos' wife Maria receives a panicked phone call from their daughter, who's shown up after school at Gabriella's house to find her mother feeling acutely dizzy and anxious, having severe difficulty breathing. Maria hangs up, dials 911, calls her husband, and they race to meet the ambulance at the hospital. Her workup, Gabriella's workup, reveals a diagnosis of COPD and bilateral pneumonia. In addition, blood tests show that her diabetes is out of control, that her kidneys are not functioning well. Once she is stabilized with oxygen, the attending ED physician, Dr. Johnson, speaks in English with Marcos, Maria, and Cecilia. Addressing all three of them equally, he informs them that in addition to the COPD and pneumonia, Gabriella is also apparently suffering from kidney failure, a complication of her diabetes, and so he would like to admit her to the hospital for observation and treatment of the pneumonia, to call for a nephrology consult regarding the kidney function. They agree. Gabriella is admitted to the ICU, where she started on antibiotics, bronchodilators, corticosteroids, and supplementing oxygen for her breathing. On admission to the ICU, the attending physician there, Dr. Parker, also speaking English, attempts to discuss with Gabriella the option of a DNR order, but the doctor soon assesses that Gabriella does not have capacity at this time to make such a decision. Dr. Parker then approaches Marcos on the matter, explaining that in patients such as Gabriella, the chance that resuscitation will work is pretty tiny. Marcos, however, vehemently forbids the DNR and says it not be mentioned again, especially in front of his mother. So the following morning, the nephrologist consults with Dr. Parker, the ICU doc, and the two of them meet with Marcos and Maria. The nephrologist explains the extent of Gabriella's disease, that she's not a good candidate for a kidney transplant, given her other problems. And further, at her age, long-term dialysis would put a tremendous strain on her body and her quality of life. And after allowing this information to sink in, Dr. Parker explains that even if the pneumonia can be brought under control, Gabriella will need a high level of ongoing care, will no longer be able to live independently, and it is unlikely that she'll be able to manage her oxygen therapy on her own. In sum, she says, Dr. Parker says that the decline in kidney function along with the COPD means that Gabriella's long-term situation does not look good. Dr. Parker, the ICU doc, then gently raises the possibility of foregoing dialysis, accepting her decline, and maybe providing hospice care instead. She attempts to convey to Maria and Marcos that hospice can provide excellent care and support of the patient, as well as a measure of relief to families as patients approach the end of their lives. Hospice can also arrange for and manage her medications and her other medical needs. During the conversation, Maria simply looks at the floor. Marcos, however, abruptly and angrily bursts out that his mother is not dying and that God will certainly protect such a saintly woman at this time of trial. He insists that they are perfectly able to care for her needs as a family, that the doctors have no right to talk about such matters as hospice when they should really be concerned with the patient's recovery. He insists that dialysis be immediately initiated, and that a kidney transplant be pursued. Okay. That's a very long case. I need a drink of water. Hold on to that. We're going to chit-chat about family medicine and ethics, and then we're going to come back to this. So, family medicine. My name's Mark Tunzi. I'm from Salinas. The guys in the white coats that came in the end, who are all of you? We did a little introductions at the beginning, so you guys missed that, but I'd be sure to like to know who you are.
We are students of Dr. Lippman. He's a psychiatrist in Louisville Hospital.
Terrific. So you're all residents, med students? Okay.
I'm a fellow pain management. I'm just rotating with the psychiatrist.
Terrific.
We are observers, all three of us.
Terrific. Thanks. Okay. So, family medicine. Family medicine is 40 years old, younger than me. It was developed as a response to over-specialization in the U.S., and my own personal assessment is that family medicine is having a bit of a midlife crisis. One of our difficulties, I think, is that if you line up 100 family docs and you ask us to define what family medicine is, you're going to get 102 answers. It's our own thing, and part of it has to do with how we got started and how we see ourselves. But the American Board of Family Practice, which is now the American Board of Family Medicine, so if family practice is out, family medicine is in. I don't know why exactly. It didn't much matter to me, but it mattered a lot to a lot of people. Yeah. But their definition at the beginning of the specialty, truly 40 years ago this year, 1969, is that family practice is a medical specialty which is concerned with the total health of the individual and family. It is the specialty in breadth which integrates the biological, clinical, and behavioral sciences. And the scope of family practice is not limited by age, sex, organ system, or disease entity. Okay. So 40 years ago, why was family medicine needed? 40 years ago, family medicine was needed because of the trend in what was happening in American medicine. You know, the turn of the century happened, and science in medicine happened, which was truly a wonderful thing. Part of that, though, in medical training led to the fact that because of the development in science and medicine, folks became specialists. So whereas in 1900, 80% of U.S. physicians were generalists, by 1950 it was down to 62%. By 1970, it was down to 21%. And so I can't cite all the people involved during the 60s of sort of figuring out that this was happening, kind of said, geez, that could be a bit of a problem if every physician in the country is a specialist. That's a bit of a problem. So family medicine was born. Pediatrics and internal medicine also saw this trend and also have tried pushing the development of generalists within their fields with, you know, from my narrow perspective, mixed success at best. In terms of the training, I think people work as generalists, but their training isn't always that way. And so by 2008, generalists have increased a little bit. On the other hand, projections, and I actually stole this from American College of Physicians, which is the internal medicine group. Projections are that the United States is going to face a deficit of somewhere in the vicinity of 35 to 44,000 adult, that's who the internists are interested in, right? But adult primary care physicians by 2025. With the aging of the population, the continued emphasis on specialty training, especially by U.S. medical students, that despite the fact that we know that there may be an issue, we're still going to be short.
When did the specialization of internal medicine pediatrics emerge?
You know, that's a good question that I'm not sure I know the answer to, but I mean, I think it started 50s, 60s, 70s. I mean, I think it sort of grew through that period of time. You know, there were specialists for the first time, and specialists were thought to be good because, you know, they knew more about their thing than other people, and I think it just became a gradual, you know.
I'm talking about the joint residency.
Oh, the joint residency. Oh, med-peds. I actually have no idea. I really think that was the 1980s kind of a development.
Yeah, they were around back then because I Hollywood went into it.
Yeah. You know, I'm very biased in terms of my own view of med-peds as a specialty compared to family medicine.
I still don't understand the difference.
Yeah, well.
Geriatrics, holistic care of the family. That's not really an emphasis on med-peds.
Yeah, I think some of it's philosophical, and then some of it actually translates into what their training consists of. You know, still mostly inpatient-based. You know, not always specifically behavioral training, geriatrics, GYN, community medicine, all the other things that go into family medicine, and we'll get to that in just a moment. So why was family medicine needed? Well, specialization, which is not necessarily a bad thing. The problem with specialization is that it became, in some ways, the only thing, or the only thing that was sort of respected, at least. But specialization had led from a shift from patients to pathophysiology, from health to disease, from the well-being of a person, really to the well-functioning of an organ or a system, right? I mean, cardiologists want to do the cardiac catheterization, and honestly, you don't call them if you don't want the cath, right? I mean, or you have a very specific question about a very specific topic, right? You know, you don't call the surgeons if you don't want the knife, or at least you're not thinking about the knife. I mean, I don't know how it is here, but general surgeons don't necessarily like doing just a consult. They do sometimes, but they really only want you to call them if you think there might be a chance for them to do their thing, which is fine. And we need those people. We need those people, just like we need psychiatrists. And I occasionally need pediatricians because I need that depth of knowledge. But you also need a different view for a lot of things. So some years back, Daniel Callahan and a bunch of folks at the Hastings Center worked with an international group of folks to talk about what are the goals of medicine. And so I've sort of, having read this article a long time ago, I've sort of kept it in the back of my mind because I think I've not seen them stated any better than this. That there are 4 goals of medicine: to cure disease, okay, to improve health, to decrease pain, and to prolong life. And sometimes these line up, and sometimes they actually don't line up. Sometimes they're actually somewhat in conflict. But depending on your view of the goals of medicine, you, if you're a specialist, probably really just do one of these, at least one of these mostly, and the others a little bit, which is fine. Which is fine. That's what specialists do. Family medicine, on the other hand, is really out to have the goal of making people feel better. Our job is to make people feel better. Now, that's very vague, and that's very altruistic, and you can say that's impossible, you know, because you can't do all these 4 things all at the same time. But I see our job is to have an eye on all of those 4 things at the same time. How do we do that? We try to treat the patient as a whole. We promote continuity of care. We'll talk about that in a second. And we emphasize a community focus that really most other medical disciplines don't do. This is a talk on ethics. We're going to come back to this at the end because I think if, you know, at least as one family physician that tries to do ethics, this may or may not help figure out why I think about why I do, why I talk about the things that I do talk about when a, quote, ethics situation arises. So Ian McWhinney was a Canadian family physician. And let me just say that the Canadians, in general, have been way out in front in family medicine for a long time, especially when it comes to this sort of philosophical, principle, background kind of an approach. But Ian McWhinney is a Canadian family doc. In Canadian family medicine, U.S. family medicine sort of grew up together. I mean, I wouldn't say that they're indistinguishable at all, frankly. I don't know what David thinks, but they do things a little differently. But in terms of approach, et cetera, very similar and grew up at the same time. So Ian McWhinney, back in the 70s, described family physicians as folks who are committed to the person rather than to a particular body of knowledge, group of diseases, or special technique. We are an open-ended discipline encompassing all ages, both genders, not limited by particular health problems, with no real endpoint in the doctor-patient relationship. So, you know, it's what makes us beautiful and what makes us ugly all at the same time. Because I'll have a patient come in with 7 problems, and sometimes I wish I were the cardiologist and could simply say, you know, I don't want to talk about any of that other stuff. I just want to talk about this for 15 minutes and get paid more than you do anyway. You know, it would be nice to have 15 minutes for one topic. Instead, we typically have 15 minutes for everything. And can we do that? No, can't do everything in 15 minutes. But that is kind of our charge. And so the trick is to be able to sort of box out, figure out the approach, prioritize things, you know, deal with all of that stuff. Okay, shift gears just a little. Family medicine adopted this notion of the difference between the biomedical model. Physicians are medical engineers who deductively apply biochemistry and pathophysiology to human illness. Sort of distinguishing between that role of a physician, an outstanding, excellent, and absolutely needed role, but only one of the roles that medicine really needs to get to. And instead, lobbed on to this notion of the biopsychosocial model. Physicians are multifaceted healers who acknowledge that people are indeed very complex, which we are, aren't we? Yeah. And part of a very complex system. So any individual has all of these things going. And the role of a family physician is to really be able to see this incredibly broad picture, so that unlike other folks who by design influence just one area, our job is to have kind of this very broad view of how what we can do influences any one of these things. So patients are members of society. They have a family, they live in a community, they're of a particular culture. They are their own person within that. And that person is made up of body systems and organs and tissues and cells and molecules. And so whether you're talking about the use of a medication that has a molecular action that then trickles up to the person, or you're talking about societal or community interventions that sort of trickle down to the person, our job is to sort of have the broad view of all of those things. It's a good time for me to stop that. I didn't have a slide on this, but when I think of the expertise that a family doc has, I think of it in a particular kind of way. In this particular kind of way that I need to learn how to do the other way too. Two kinds of experts in the world. There are these kinds of experts, what I call vertical experts. They know a lot about a narrow topic. All right. And then there are the kind of experts that I see generalists as, family docs in specific, very, very broad expertise. Do we know any less or any more? One person to the next, sure. But in general, I don't think family docs know less. We just know different stuff. The expertise is this way. You can think of analogies for yourself, but one of the analogies I like to make is, Michelangelo was a sculptor. No, he also painted. Okay, fine, he did other stuff. But bear with me for a minute. But, he was a sculptor, and he was maybe the best ever. Leonardo da Vinci, was he the best at anything? You could argue that, but probably not necessarily the best at anything. David reminded me of an example the other day. Ben Franklin. Was he the best at anything? Was he the best statesman? Was he the best musician? Was he the best inventor? Was he the best at anything? But he was awfully good at a lot of things and made a real difference. So I sort of see family medicine that way. Now, when I'm writing a paper for Dr. Hansen, that broad expertise doesn't always get me very far, because he always writes me back a little comment that says, it'd be nice for you to drill down a little bit more here. Indeed, he is right. It would be. And I'm trying, and it's just not what I'm good at. It's just not what I'm good at. Should I be better? Sure, I can learn. But it's not what I'm good at. So, to some extent, do people become their specialties, or do the specialties become their people? I don't know. So if you have a particular personality style, do you gravitate more towards one field or another? Yeah, I think so, probably. And then I think once you're in that field, you also sort of, if you want to excel at what that field is, you also fill yourself out to do that. So, I consider myself, I'm not sure I'm an expert, but if I am an expert, it's this kind of an expertise. So, clinical attributes of family medicine. One is access to care, that we really promote being available to patients. So, if you look at community and community migrant health centers nationally, mostly based on family medicine models. Not exclusively, that's for sure. If you go to rural areas, mostly based on family medicine model. Not exclusively, but pretty much. Because we're the specialty that really believes in access. Right? Continuity of care, including chronologic care, care of patients over time. Again, no end to the doctor-patient relationship. And quote-unquote geographic care, so care in the office, the hospital, the nursing home, although not really so much because it's hard these days. Comprehensive care, so again, all ages, both genders, all kinds of problems. Walk in the door and we will deal with you one way or the other. We may do it ourselves, 80, 85, 90% of the time. we'll get help when we need it, which is why we need all of you. Coordination of care got a bad rap under President Clinton. This is a gatekeeper thing, but good family docs have always done this, right? You come in, we figure out what needs to be done. If we can do it, great. If we can't do it, we figure out where to send you for help. And again, we need all of you. And contextual care, this notion that, back to the biopsychosocial model, people are part of this complex thing, and that our job is to try to take care of people where they are, meet them where they are. Because if we can do that, we do a better job of figuring out how to make an intervention that's going to be successful. We are, at the end of the day, pretty pragmatic, most of us. You know, the goal is to make people feel better. Do I care how I do that? Most of the time I don't, to be honest with you. Yes, I do sometimes. I mean, you know, I have limits like everybody else, but the goal is to make people feel better, whether it's take care of their acute problem, whether it's plan for something in the future with prevention. My goal is to deal with all of that stuff. If the patient comes in and simply needs permission to drink their chamomile tea, hey, that works for me. Chamomile tea sounds good. Every now and then I'll have somebody ask me, well, you know, you're giving me this medication, but I'd like to do this. And they look rather embarrassed. And sometimes it's almost always by accident, to be honest with you. Hey, it's fine. You know, yes, I'd like to know, because I'd like to be sure that it doesn't, you know, if it's an herbal thing, it doesn't interfere with something else or cause them problems that they're not aware of. But hey, if it works, that's good. So I have no problem with folks seeing the psychiatrists and, you know, doing something else to handle whatever their behavioral issue is. We are pragmatic. Shift gears again for just a moment. Contemporary family medicine, the interactive models of the patient-centered clinical method. Again, a group of Canadians. But this is probably close to 20 years old now, so sort of in the middle of the history of family medicine, which is 40 years old, as I mentioned. Really decided to emphasize the notion that patient care, and particularly family medicine-oriented patient care, needs to be patient-centered. We take care of people. We take care of individuals. We don't take care of a disease. We don't perform a procedure. We take care of people. That's what we're about. Big people, little people, people. Okay. So their components are first, to explore the disease and the illness experience. Is there a difference? Absolutely, there's a difference. Because the disease is what we treat, the illness is what the patient has. All right? So the notion would be to understand that. Understand our approach. You know, we're looking after an illness, and what the patient feels, and to try to be sure that, you know, where they cross, where they lined up, if they're not there, that we understand that and that we can address that, consciously address it. To understand the whole person, so that means knowing something about their background, the context, again, of where they live, their family, their environment, their upbringing, their education level, all of that stuff. Finding common ground regarding management. It means you need to know what the patient thinks they want. You need to know what you think you want. You need to try to figure out where they come together. So this morning, when I was talking specifically about sort of a cross-cultural case of this, you know, non-Spanish speaking indigenous Mexican patient, blah, 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 you know, one of the issues there in that particular case, not too dissimilar to this one in some ways, is, you know, what do they think is going on? What do we think is going on? And let's figure out where they come together. Incorporating prevention and health promotion. Again, family docs, our goal is everything. So we really also want to plan ahead, right? So you want to be sure that, you know, the reasonable, you know, prevention measures are addressed. Okay. So, you know, you look at the folks that have worked on the U.S. Preventive Service Task Force, a lot of family docs there, a ton of family docs in that group. Enhancing the patient-doctor relationship. That's not a typo. It's the patient-doctor relationship that they want to enhance. I'm going to talk about Howard Brody as a family doc in a minute, and one of these days, Dr. Dukas will get a real family doctor up here to talk about philosophy and family medicine. But there's notion of sharing power. It's one of the references. Oh, you don't have references yet. It'll be on the screen at the end. I'll let it sit up there. This notion of sharing power. So Dr. Brody wrote a book called The Healer's Power. You know how in healthcare we have the power, patients don't have it, but we really need to sort of share that power together if we're going to work together. It's not really a contract exactly, but it kind of is in the sense that we have roles, patients have roles. We need each other, right? For us to be successful, we need the patients to step up. And lastly, being realistic. Because if we're not realistic, nothing happens, right? Nothing happens. So I like to pick on, since the psych guys are in the back there, I like to pick on the psychiatrists who say, okay, here you have the schizophrenic patient who comes to the hospital, gets admitted, goes in the psych ward, gets their medication, finally gets controlled, and then is told to go home and make themselves an outpatient appointment. Now, I understand that the patient needs to take some responsibility. But I also know that depending on who the patient is, forgive me for being politically incorrect, but, it's a crazy person. And, they need help. So you need to give them responsibility, but we also need to sort of help them along. And our place is pretty good about that. I like to tease them once in a while, but they're actually pretty good about it. I'm sure you guys are here as well. But you have to be realistic. Some things will work, some things won't. And if we're not realistic, if we're not pragmatic, we don't follow up, we don't make sure all those things happen, then things may not happen well. In other words, we can't just be the medical model. We have to think about it in a patient-centered way if we really want a successful outcome. Okay. So the bottom line is that we are pragmatic generalists who understand that our relationships with patients, the relationship is actually one of our therapeutic tools. It's the relationship I have with the patient that actually helps good things happen for lots of reasons. They want to please me. It's kind of humbling to think about it, but to some extent they do. They want to please me. They come back, they keep their appointment. That my relationship with them, the way I say things, matters. So I'll sometimes tell the residents, you can be the smartest doc in the world and always be right. But if your patient only understands what you're telling them 60% of the time, you're only going to be 60% successful. On the other hand, you can be only 2/3 right, which is, what, a D maybe? A C minus? Okay. But if you can communicate with your patient in such a way that the patient always understands what you're saying, you've actually come out ahead of the guy that's quote-unquote always right. Now, hopefully we're right more than just 2/3 of the time, but the idea is that our relationship with patients, our ability to communicate, to connect, to do all of those things is actually very valuable. So, family physicians as clinical ethicists, getting kind of to the point here, okay? Dr. Brody, who I mentioned, really distinguished in his book between the engineering model and what he calls the conversation model of ethics thinking. The engineering model being very deductive, principle-based, fact-specific. So a engineering model ethics thinker would never present you this case. They would present you maybe that much, or 10 bullets of what they think the facts of the case are really about, and then toy with those kinds of things. Okay. Content experts. So they're content experts in terms of the principles that they want to be applied, et cetera. Sort of an intellectual, asocial activity that I link back to the biomedical model. Sort of a deductive, engineering, thought-based approached way of analyzing and thinking and discussing a case. Versus sort of a conversation model, this very messy, inductive, detail and narrative-based, process expert, transparent social activity, more related to the biopsychosocial model, society, family and culture, person, organs, systems, blah, 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 molecules. All of that stuff is somehow important. So Dr. Brody's question is, what, all things considered, ought to be done in this situation? Okay. At the end of the day, after you've thought about everything, after you are weary of talking about all the different facets of the case, what do you do? And in fact, if you don't think about all the different facets of the case, you're not going to really arrive at what to do. He's a narrative ethicist kind of a guy, at least that's my impression of what he might call himself. And I'm not sure that I am necessarily, but as a family doc, I appreciate that approach to dealing with cases. Because if you don't do that, you sometimes lose the entrance to the solution. So I'll tell you briefly the same story, different case. Very simple story of a case that happened, a real-life case that happened about a month ago, that those of you who have already heard it once, sorry. So I'm walking down the hallway one afternoon about 1 o'clock at the hospital, a little bit past noon, and my friend, Tony Galicia, who's a physiatrist, who's the chair of our ethics committee, said, Mark, you flagged me down at the end of the hallway. Do you know about this case? Okay, well, no, what case? No, I don't know about a case. So he says, well, we have this patient on labor and delivery. I just got a call from the OBGYN doc. This Mixteco-speaking lady speaks an indigenous language, not Spanish, pregnant with twins, one's vertex, one's breech, needs a C-section, and she's refusing. Okay. So, I guess we need to call I guess we need to go sign something, or we need to call a hospital attorney. And I said, yeah, okay. I said, well, let's just think for a second. So we have this concern about capacity. Is she really understanding what's going on? Is she really able to refuse this thing because we're not able to communicate with her? And I said, so we talked about it. I said, look, I do OB. All of our family docs do OB. I said, let me wander over to labor and delivery and see if I can figure out what's going on with some of the case. And why don't you get a hold of the hospital attorney, the county council, the Monterey County Council, whose role is taking care of the hospital. You call him, let him know what's going on, see what it would take to get a judge if we could do that, make sure that folks are comfortable with the fact that, we're going to wind up doing a C-section here. I mean, I smell it, but let's you do that, and I'll go over and deal with the case. To make a very long story short, it took me probably 10 minutes talking to the nurse, looking at the chart, talking to the patient to figure out who the patient's primary doc was, figure out the patient's Spanish actually was pretty good despite trying to go through all this translation stuff. Call the primary physician, who identified the patient as my friend, which is true. Talk to the primary doc, go back and talk to the patient, and basically problem solved. Patient said yes within half an hour, had a C-section, had healthy babies, and everybody was happy. But it was really a question of communication. And I'd like to say I did this great thing, and I just did what I do, frankly. I looked at all the available information I could find, and I tried to figure out who all was involved, and the husband wasn't there, so he wasn't a choice right at that time. But I realized I knew who the primary doc was, and I called that person, which is really all it took. They were all really happy that we solved this problem. The OB docs thought we were just, these great ethical thinkers. And all I did was make it big enough, made the case big enough to solve the problem. So, what all things considered do we do to get an answer that's the right answer? Future Family Medicine. There was a project a few years back, I think 2004, so just about 5 years ago now, between the American Academy of Family Physicians, the Society of Teachers of Family Medicine, the Association of Family Medicine Residency Directors, and a couple of other family medicine groups to try to look at the future of family medicine, alluding back to this midlife crisis that I was talking about. Who are we? How do we define ourselves? Because if we can't define ourselves, it's going to be hard to explain to other people who we are and what we do. And they look back at sort of all of the philosophy stuff and where we are and where we think we're going to go, and basically said that family medicine is the specialty that provides continuous, comprehensive, compassionate, personal care within the context of family and community. So kind of just rephrasing all that stuff that I mentioned from 40 years ago. And they also listed 5 key characteristics of contemporary family docs that we really are folks who have a deep understanding of the dynamics of the whole person. So back to all that stuff I was talking about. We're whole person based. That we have a generative impact on patients' lives. We are involved in anywhere from newborns to end-of-life care. Maybe we don't do it all by ourselves, but our role is all of those places. And so we really try to build this relationship with patients and have it be a constructive thing that lasts for a long time. That we have a talent for humanizing the healthcare experience. That we have a natural command of complexity, which is to say we're either smart enough or stupid enough to juggle all these balls or try to at the same time. And that we're not afraid of that we somehow accept that as our lot in life, that our job is to be able to deal with all of these things and not narrow down and say, I'm sorry, I don't do your pap smear, you have to talk over there, or your chest pain is not cardiac, so now you've got to talk over here. That we are willing to juggle all of these things at the same time. And that we have a commitment to multidimensional accessibility, meaning that we try to provide access in lots of different settings, that we'll talk not only to patients, but we'll talk to families. We'll try to deal with all of that biopsychosocial model stuff and make our inroads in there wherever we think we can, trying to stay practical, but also trying to realize that different people may need different things from us at different times. So you take those 5 things and translate it to a family physician as a clinical ethicist, at least my idea of what it is that I bring to thinking about clinical ethics issues, and it's investigating and examining the details of a case, all the little details of a case. Again, not rocket science. If those of you know Al Johnson's little 4-box method, he has on there medical indications, patient preferences, quality of life, and the context. Okay, not necessarily so different from that, but as a family doc thinking about a case, I want to know about all these things. To the degree that I can, I want information of all these little pieces. And that, my idea is to bring to the table my ability to integrate all of those things at the same time. As a family physician, that's what I do. Right? I mean, I look at all the different parts of what's going on with somebody. Not just the lungs, not just the heart, not just this, not just that, but everything, and see how they fit together. Work as a member of a multidisciplinary team. I mean, family docs are sort of natural team players. 1, because we don't know everything and we need everybody's help. But 2, because, we're family physicians, and, families are these big, messy things, and we say we like that, and so we practice it some. As a family physician interested in ethics, I see part of my job as humanizing the deliberation, keeping the focus on the patient, on the person in the context of what all is going on, right? And using the mastery of the complexity of the situation to be able to communicate with everybody. Communicate with the patient, communicate with the family, communicate with other folks on, say, the ethics team or on the clinical team, and then communicate to others who will be involved by making sure that the communication in the chart, whatever it is also accurate and understandable. So as a family doc thinking about ethics cases, that's what I try to bring. So that was a lot of talk. Time for a glass of water. So you guys that came in late, did you grab the case? Okay. So hoping you had a chance to look through that, because what I'd like to do now is just sort of ask you. We have 35 minutes, yeah? Terrific. To maybe use the case to talk about some themes and anything else that came up. What I understand from Dr. Dukas is that this normally goes for 45, 50 minutes, and then it's sort of an opportunity for a discussion. So I'm good for discussion with any of the things that I presented, but I'm also good with discussion with stuff relates to the case, because I think maybe we can use the case as a way to bring some of this stuff back in.
What's most striking about the case is we don't know what Gabriella wants. We know what everyone around her wants. The problem lies in the fact that the traditional American or Western culture of bioethics is you have to ask the patient. You're supposed to find out from the patient. However, there are other cultures that say, no. Family makes the decision.
Right.
And in circumstances like that, we sometimes try to deal with that by asking the patient, who would you want to make your healthcare decisions? You're able to make your own healthcare decisions. I'm glad to talk to you about this stuff.
Sure.
Do you want your son, who has the identical medical problems and he ignores life flagrantly,
Right.
to make your decisions?
Right.
Or would you like your own healthcare decisions because your end-of-life care is going to be based on that without actually introducing the end-of-life care part?
Right.
But if she proclaims, yeah, it's great for my family to make these decisions for me. Well, you have an autonomy waiver, and you can move forward with that, and the family can make those decisions. And you can always say, okay, well, I can let you come back in anytime you want to start talking about it, too. You can give her sort of an escape route to say, I want to go ahead and be the participating member here.
Right. I mean, clearly, one of the themes in this case. One of the themes in this case clearly is capacity. Does the patient have capacity? Does the patient not have capacity? And as capacity relates to consent for doing and not doing things, you know, how in this case does that get addressed? How in this case does that get resolved? Yeah, I would agree. I came up with three themes of my own, which I'll get to in a minute. But that clearly is one, absolutely. You had your hand up first, and then you, sir.
The thing that's striking me is that medicine has not served Gabriella well. Medicine meaning the whole, like the doctors, I mean, the whole service has not served her well.
Yeah.
I mean, she can't afford her prescribing meds, she can't afford, she doesn't forget, she doesn't have a good understanding of the disease processes. And once we've been in there helping her and her family, her granddaughter's there every day. You know, so doctors are saying, you know, take your whatever you're taking, and she's like, yes, I'll try, and then she goes away, and now all of a sudden she's sick, and from the family's perspective, she goes to the hospital and says she's dying, go to hospital.
Yeah.
It's like, wait a minute, you know, I mean, that's a shock. I mean,
Yeah.
so I don't know that the medical community have done much for this patient, either before or now,
Yeah.
from their perspective, and
Yeah.
mine too, actually.
Yeah, right. So the question is, how effective has the medical community been in the care of this patient over the long haul? Yeah, you, sir.
A few questions. This lady had some contact with the physician. Who was that physician, and was he contacted when she was admitted to the hospital?
Excellent question. So it would have been a community clinic-based physician. And as the case was written, I don't know whether that person knows she's in the hospital. Probably more than one physician. Probably more than one physician over a period of years, I'm going to guess, just based on how that goes in our area.
Then I have one other question. Was there any attempt made to get a Spanish-speaking physician to talk to Gabrielle?
Once she's here in the ICU. That's an excellent question. I don't know.
Because I think she's at the center, and the decision was made that she could not make decisions.
Right. So was there a Spanish-speaking physician or some attempt to do some sort of translation? Because if part of what this case depends on, at the end at least, is asking the question, does she or does she not have capacity, then we have to know that there was the right attempt made to actually communicate with her. Yeah, absolutely.
I wonder, the sidebar to what Dr. Simon said regarding the failure of the medical system. If this is not a story of a woman who has succeeded rather well without over-dependence upon the medical system, she's 80 years old. She's lived with limited resources. She's lived in a rather isolated area. She's had a hard life. But she's 80 years old. And now that she is 80, she's suffering from a precipitous decline in her health. But I think there's something remarkable about this lady. We tend to think too much, it seems to me, in terms of the obligations of physicians toward the patient. And you don't even have access to those patients. But some of them live quite well. Here's one who's a pretty strong woman.
She has been, in fact, right. I mean, you could say that with her life circumstances and her medical problems, that up until this moment, she has lived quite successfully, even if the medical care system has not necessarily served her in a perfect manner. Yeah, I think that's probably right. I'm trying. I'm trying to rephrase the question. Sorry. Yeah, I think the point is well taken. She is a remarkable woman. She has done very well, given where she's come from and what she's had to deal with.
Worst word
Yeah.
here, she's above life expectancy.
She's above life expectancy. Yeah, probably. Yeah.
As a chaplain, and notice her son invoking God as the ultimate rescuer here of her. Going back to your slides about the goals of medicine, he sees the physician's goal as to cure disease, extend life.
Yep.
And the physicians are honing in on the goal of reducing pain and a quality of life issue. And so the goals are not shared goals. And what makes this difficult here is, in my estimation, is that the battle lines are now drawn. It feels to me that son and family are invoking God versus medicine, which is really not the place to be. That becomes a very difficult discussion to have, and it's hard to be collaborative when someone gets angry, bursts out, starts telling people what they should or shouldn't be saying. It's a very difficult collaborative situation.
Well, that's right. So the comment is that in this case, the son is invoking God and the goals of medicine of curing disease and prolonging life, whereas the physicians really are looking at more the goals of decreasing pain and looking for the best sort of outcome in this situation, and that with that conflict, which may be an irresolvable conflict, we sort of have a setup for things not going so well.
So now having the benefit of seeing where that conversation takes this situation, this probably could have been helped by a much slower approach, to not be driving towards decisions during that first conversation.
Yeah. Yeah, they clearly, the way this case is presented, the hospital course of a day has sort of gone on warp speed here, hasn't it? I mean, when you're in the hospital, and it's what you do all the time, I have an understanding how sometimes that happens, but that's our shtick, right? And that's our approach. I mean, that's sort of the biomedical kind of, this is what we do all the time approach, and so we see the handwriting on the wall, let's go ahead and finish drawing the picture. Yeah.
My concern is, now I know this is like a made-up case and stuff, but when I look at this is a woman who is, functional with help from granddaughter, presumably never hospitalized before. If this was, say, my grandmother who went to the hospital with her diabetes and her COPD, would they be saying, oh, let's not even think about this, so let's call hospice? Are we doing it this fast because we know she's poor and has no resources? I mean, that's an ethical thing I'm thinking, because exactly the speed at which we went, and I'm going, well, you said her kidneys are bad, but you didn't say they're end stage. This is her first COPD attack that I know of. She's not on the vent. She's on oxygen. I mean,
Right.
what's happening here? I'm a little concerned about that.
Right. Right. Exactly right. So this case is, again, has gone very fast, and part of the question is, has this case gone this way because of some of the specifics about her that might not have gone the same way if it were one of our parents or grandparents? Point well taken, because I wanted to make a couple other little points here. For me as a family doc, when I look at this case, when I looked at it the first time, the three real themes that stood out to me, sort of blending ethics with family medicine, were communication, compliance, or non-compliance, and capacity. Clearly capacity, because at the end, that's really the question of capacity and consent. Who has the ability to speak for this patient? Does she? And are we certain that she doesn't? And if she doesn't, then who? Marcos has 5 brothers and sisters. The case says that 3 of them live out of the area. That means 2 of them are in the area. And while it would appear to be fairly clear that of the siblings, he has the closest relationship with his mother, at least as the case is written, and that it's his daughter Cecilia that goes there, most afternoons after school. Pretty powerful relationship there. The point Dr. Dukas made earlier about decision-making styles really does come into play a bit, which is to say, we are very used to the autonomy-based individual right to manage my healthcare decision, which we can't exclude here. We do need to try to figure out whether Gabriela has capacity or not. Have they tried speaking with her in Spanish? Have they put things in terms that she might be able to understand? She's obviously ill. Have they gone back at enough different times to be sure that they're trying to talk to her at a good moment, not necessarily at a bad moment, all of that stuff. And on the other hand, my experience with the Latino families is that they rarely engage, even when an individual patient has capacity from a Western perspective, they rarely engage in autonomy-based decision-making. They almost always engage with, I'm not quite sure what to call it, so what I call it is a family consensus mode of decision-making, which is they don't decide just for themselves. They want everybody in the room to talk about it. If not absolutely everybody, nearly everybody. So it's not unusual to have a family meeting with all the siblings present. And they refuse to have the meeting until the siblings from 6 hours away can drive up on a Saturday afternoon after they haven't worked. They get off at noon and they'll drive up. I mean, it's not unusual for that to be the way that decisions get made. So in fact, to reach back to something that when Dr. Jeffrey Spike was here a couple years ago now, because I checked in with Dr. Dukas this morning to see when he was here, if any of you heard his talk about consent, he has this notion of consent that's a little different than the traditional notion. Jeffrey's notion is that you've got to be able to understand information, you've got to know how it relates to your case, you've got to be able to communicate a choice. But he kind of substitutes the notion of being able to reason with the information, because who judges what's reasonable? He kind of substitutes for that this notion of authenticity, that you really want to make decisions that are consistent with your values, that are sort of authentic to you as a person. And there actually was just a very nice review of authenticity from another author whose name I forget in the very last issue of the Hastings Center report just came out, talking about authenticity and how authenticity and autonomy are not exactly the same. They're related, but they're not exactly the same. So, what's authentic to Gabriela on the one hand, and the other hand, and the ability to express a choice, one of those parts of consent that everybody does agree with. Well, who has the ability to express a choice? Gabriela may or may not, but Marcos may or may not, because he may not be able to feel as though he can speak for his family, his siblings, and he knows that he needs a consensus decision amongst them in order to really talk about this. So, if we force him too soon to be the spokesperson without giving him half a chance to connect with his siblings, we may actually be shooting ourselves in the foot just a bit here. So clearly capacity in this case is an issue. We've already alluded to a couple of different communication things. So, hold on.
This case reminds me of the article in JAMA recently that talked about the coping mechanisms in religion, various groups, how they do that at the end of life.
Mm-hmm.
Here is a man, Marcus, represents that point of view, that out of religious commitments or values insists on everything. That doesn't necessarily represent Gabriela, it seems to me. She's gotten along pretty well without this whole apparatus to this point, and now consists on this issue. Is that a general perception that you would share with regard to minorities? Because this article said that this is especially true among what we refer to as minority groups, that is, in Texas, where most of these people are drawn, Hispanic-speaking background people and blacks. And it also relates to a more or less charismatic type religion, where they really believe in miracles, divine intervention, what have you.
Yeah, so the question is sort of the role of religion and or faith in minority ethnic groups and how it influences their care, if I heard you right. I have little to zero experience with African American patients. It's just not my part of the world, so I'm not able to speak to that. With Latino patients, which has been my end of the world for the last 15 plus years, it's variable, but there certainly is a common theme amongst many families, this notion of God will take care of us. I can think of 2 or 3 consults that we've done over the last several months and where this very issue came up. You know, do we back off on care? Do we not back off on care? And the family's, oh no, you can't possibly back off on care. Part of it, I think, is a bit of paranoia and suspicion of the medical team, but it tends to be versed in the language of God and religion and waiting for miracles and playing God and all of that kind of thing. So for a lot of Latino patients, yes, it's a factor. You know, it's variable. I don't think it's one size fits all, but it certainly is a more common theme than arises in the majority of the, you know, non-Latino patients that I care for.
Part of it can be semantic too, because the whole notion of withdrawing care implies that everything is going to be stopped, whereas withdrawing treatment has to do with those things which are deemed non-beneficial or that the patient refused, but you're still going to be providing care in a variety of modalities of palliative treatment. And so families are communicated that there are many things that we can do to make your loved one feel better or feel okay during this time, as opposed to we're withdrawing care. And I think sometimes a doctor or a nurse will say that without realizing what they're saying.
Right.
And we try to make a habit on our ethics committee to say withdraw treatment. It's something that's a little thing I learned from Sally Nunn, who is the one who ran the ethics committee at the University of Pennsylvania.
You know, as a family doc, there are a couple of other issues that I think strike me more as a family doc than may strike folks that would look at this case from other perspectives. One is communication that we've already talked about. And the other, again, is this notion of compliance or non-compliance, you know. So here's a patient who would have, and I'm trying to think, you know, as I mentioned at the beginning, I'm a family doc, I think like a family doc. When I work with other people, I do my best, and I think I fail a lot of the time, but I do my best to try to think like they're thinking, try to think like my patient's thinking, anticipate issues, thought process, etc. So trying to think a little bit like the docs in this case, who may, you know, it's not clear what all they know of Gabriella's history at this point. But what we know about her is that, you know, she has been, to some degree, non-compliant, right? She hasn't always taken her medications. She hasn't always followed up. You know, she hasn't always done the things that the medical community has wanted of her. Marcos, you know, another major actor in this story, Marcos clearly is non-compliant. You know, he doesn't want to address his drinking. He doesn't want to take medications. He doesn't want to get blood draws. You know, he doesn't want to do things that, again, the medical community is asking him to do in order to take care of himself, right? So it's not, I mean, you know, we've all seen it. As soon as a patient or even sometimes a whole family gets labeled as non-compliant, you know, things in our thinking change. So the question was asked earlier, you know, do we think that part of the way this case has gone is dependent on her being a poor Latina person? Maybe. You know, has part of this care gone the way that it's gone here at the end because she's seen as that plus maybe not such a compliant person anyway. You know, as a family doc, the big problem with that, of course, is that non-compliance is you know, it's a clinical / ethical problem, because non-compliance rarely is because patients want to tick me off on purpose. Non-compliance is because of financial barriers or transportation barriers or education barriers or contextual barriers. I mean, there's lots of things that go into why a patient is not ready or able to do the things that we ask. Maybe they've got a behavioral health problem. Maybe they don't understand, not because they're not intellectually able, but because they don't know the vocabulary we're using, which may or may not even have anything to do with education. You know, I mean, there's lots of things that go into this business of non-compliance. And it's not an issue in clinical ethics that I think is specifically addressed a lot, but as a clinical family doc, it sure is. And so, I sort of wonder, as I read through this case, I wonder, what's the role of noncompliance? And, does that have anything to do with some of this at the end? Patients aren't going to do well, et cetera, et cetera, et cetera. In one order or the other. Go ahead.
Speaking to the compliance issue and lacing it through the religion issue, they might say that we've been very compliant. We've been compliant with our mission. And faith has preserved us to this point. I wouldn't argue that from my perspective, but
sure.
What we're saying is not compliant to the directions of medicine. Not. But that's a different label than a globally non-compliant.
Right.
They may have shown.
So in fact, they have been compliant from their perspective.
They may have been compliant. They may not
Right.
all.
Right. So back to the family medicine notion of trying to be patient-centered, trying to think about this biopsychosocial thing. They may be very consistent, very authentic. And then the question is, whose job is it? Whose job is it to bridge that gap? I mean, has to be my job.
But when a family patient shows up in the hospital and asks for medical opinion, medical treatment, but then responds and confronts that with religion, that is the place of their ambivalence. That's where they're from. I call it cake and eat it too medicine.
Mm-hmm.
In a number of conversations I've had with patients, families, we're going to give the patient full court press, and if God wants them, God's going to have to take them. And my thought is, God's trying. We're standing in the way. And to try to help them see the God-human partnership, medicine included in that.
Right. And you said something else that I think is very important, which is when any of us make a recommendation to a patient for care, for thinking about this compliance thing, when we make a recommendation to a patient for care and a patient doesn't follow that recommendation, it really does, it's our job to figure out why. And it's our job to figure out why, because the why may be for a really good reason from their perspective. Physicians, parents, politicians, we all tend to get kind of ticked off when we say, I know what's good for you. Why can't you just see it and agree with me? Teachers, Yeah, right. And the thing is that there's a role for that, and then there's a role not for that. Right.
So this case sounds like my everyday, right? And I see a whole bunch of things that they didn't do, and you brought up, some very key things, one of which is the family meetings, because obviously you want to have them there, you want to have all of them there, because they're going to need to work on solving this, and you need to have it in Spanish. Obviously, since that's their main language. But the other thing that I'm not seeing is one of the first things that we talk about is what they understand about what's going on. So we've done a whole bunch of talking to them. I don't know what they've gotten from it. So
Right.
they need to tell us. And then we need to find out from their perspective how it's been going with Gabriella up to this point. And then what's important to Gabriella. We need to learn about her. And then we need to lay out to them the various options and what it looks like and what it's going to take from them. And we also need to put in our part the expertise about resources or whatever to help them with whatever they're picking.
Right.
So that is what you need.
Right. There needs to be a lot more. There needs to be a lot more communication. And my take on this case is that there wasn't nearly enough communication over the years. So she went to a diabetic educator once. What's that all about? Once? If she's been non-compliant with her regimen for any set of reasons, that's gone on for years. Communication for a period of years hasn't gone well. With Marcos, the connection with him, the case is written the way it's written, right? But it certainly doesn't sound like the communication there has gone well. And, part of communicating as a medical person, as any content expert person, right? With any kind of of education system. You've got to, you know, the old adage is, you tell them what you've told them, right? Or that whole kind of thing. But exactly as you say, you also have to get back, did they hear what I said? Because if they don't hear what I said, then I haven't actually communicated very well. I mean, to me, when we talk with residents about providing informed consent, that's the place where it always bogs down. Yes, you have given information, but have you informed them? Have they heard you? Have they understood? Have you checked in? Have you done that? And in this case, it doesn't appear to me that over the first umpteen years of this case, that really has happened very much at all. And now, at the end, they've tried to make up for all of that in one day. In one day. And from my perspective, made one huge mistake along the way with respect to Marcos. And it's a little thing. It's a little thing, but, you know, again, trying to see things from somebody else's perspective. If I were Marcos, and the physician was speaking to me, my wife, and my 15-year-old daughter equally, I would probably be a little bit annoyed. You know, because I think I would figure out that the reason they're talking to the 15-year-old daughter is because the guy doesn't think I understand him. And so he's making sure that there's one good English speaker there, the 15-year-old teenager who probably speaks, you know, perfect Valley-ese. You know, so the physician is comfortable in having her participate because that's the one person the physician knows understands what he's talking about. But as the parent, you know, I would be somewhat offended by that, I think. And, you know, at any rate, so that's one little thing. But they're trying to make up for all of that in one day and clearly moved way too fast in covering all of these things. Here's a woman who, until this morning, was thought to be independent, strong, strong-willed, etc. And, you know, by that evening, things have changed, and by the following morning, they're talking about hospice. I mean, we've not given this family any opportunity to handle the information, to let it sink in, you know, and we're really giving them information in this very medical, direct kind of a way. You know, it's not pastoral care here that's being given these folks, and we're not giving them a chance to take a step back, let it sink in.
That's a commonality between family medicine and clinical ethics, is that we both deal with circumstances in which there is somebody, either a patient or a family member, who is in cognitive dissonance. They are imagining that things are in one way when objective data may tell us that they're quite not that way. And we have to break the news to them that the reality that you perceived all this time is not true. So, like telling somebody about diabetes, I felt fine, but I just had a little symptoms of X, Y, and Z. Well, you have diabetes. Oh, I don't have diabetes. And that's what Marcos is doing.
Right.
And now you have a circumstance where you're telling a family, she was fine, everything was okay, except for a little bit of this or a little bit of that, and a few symptoms of this and that. Now she's dying. No, can't be. And so typically we have to deal with those big step-offs of function or step-offs of changes of life in which we have to exercise empathy coupled with communication, coupled with patience. We're having to sort of help walk with them down a pathway towards a new corridor of their life. Because where they were going, that old corridor, is now a dead end.
Right.
And we can't go that way anymore because the body's not there anymore to do that. The body's going in a different direction.
And I think what family docs bring to the clinical ethics discussion really is this notion of, you know, back to the principles of family medicine. You know, access. Do you have what you need? Continuity. We're here today, we're here tomorrow, we'll be here the next day. You may not be if your insurance changes and all kinds of other things may happen, but we're still going to be here. And that while some things are truly emergencies, a lot of things are not as emergent as we think. And sometimes they're emergencies and I deal with them. Clinically, it's fine. Sometimes I need help in dealing with the emergency. But sometimes the emergency is just the plan. In other words, the solution to the emergency is the plan. It doesn't matter what you do today. What matters is that you have a plan on what you're going to do today and what you're going to do tomorrow. And so one of my responses to this case is, this is how she is, but they've created an emergency when, sure, things have changed and things need to happen, but it doesn't have to happen within a 24-hour period. You know, somebody asked earlier about, well, where's Gabriella's doctor? Yeah, okay, you know, it might take a day to track that person down, you know, but why don't we track that person down? Why don't we build some confidence by bringing the continuity back in and giving them a sense of continuity, that this isn't something that has to happen today. We have to have this conversation. But here's some information. Let's continue to talk about this. You need an opportunity to let it sink in. You need an opportunity to get the rest of your family together. You need an opportunity to ask some questions. We need to be with this together. Bring the priest. You know, you want to talk about miracles? That's fine. I'm delighted to talk about miracles, but you don't need me for a miracle. Okay? You don't need me for a miracle, but I'm open to miracles. I mean, I tell patients that all the time. So you have a priest? Bring the priest. Let's engage that person in the conversation and see how together we can work through this. You know, the other parts of family medicine, you know, they kind of, you know, for me, when I look at this case, they truly weave together when I think about how I approach this as an ethics-y person and how I think about it as a family doc. Andrea? Yeah.
This is actually kind of just a synthesis comment more than a question. So is that what Marcos is doing here? Is that another perspective on Marcos' behaviors? No, you absolutely have to keep her alive until my siblings can show up, until I can get my 15-year-old daughter out of the room, because I don't want you to tell her that her grandma is dying, that she loves and spends every day with. I want to be able to be there for her when she comes to deal with this. You know, it seems like all of these things, the goals of care are kind of, yes, in conflict, but some of that might just be integration.
Right. So another way to look at that is Marcos trying to be family-centered here?
Yeah.
You know, if we're not patient-centered because the patient doesn't have capacity specifically, can we be family-centered with this care? And is Marcos trying to do that, and yet the treating team isn't? Yeah. 1 minute left.
One last comment.
It occurs to me that there's a fourth C that might go on your list, and that is conflict. Different perceptions of the situation, different commitments, values, orientation, what have you. And conflict is both a predictable and almost a necessary factor in every clinical setting. You could have differences of opinion.
Absolutely.
So the question is, how do we manage or think about ways to manage conflict?
Maybe conflict resolution.
Yeah, yeah. Yeah, I think that's exactly right. Conflict resolution as an approach to this. There was an article some year back, who's the name of the woman ethicist that wrote it, I can't think, but basically talking about the sort of negotiator role of a clinical ethicist. Walker, I think was her name, Margaret Walker. And you know, the difference between negotiating with people and sort of solving problems from a top-down approach. And yeah, so family docs as negotiators is certainly one of the ways to address conflict. Well, we are right at time. Thank you so very much for coming.